This is an older dog which has had puppies. So I am expecting the uterus and ovarian pedicles to be more fragile. Because of this, the incision is made closer to the umbilicus. The uterus took longer to find due to the large amount of fat in the broad ligament. Because the dog has a higher risk of friability and the ovary is quite well exposed. I don't break the suspensory as I want to use it to protect the ovarian vessels. I want to use a clear window, which is a good distance from the ovarian vessels, and is low down, so the ligatures can be pushed down. Carmol clamps are the best, as these are least traumatic. Walk the clamp down the pedicle, lowering it as much as possible. Place your two clamps above the ovary and perform a uterine separation. Keep the ligature loose and nudge it down on both sides of the pedicle. Rotate the pedicle clamp so the ligature grabs lower down. Release the top clamp, mop up any blood, and release the pedicle clamp, raising it so it still clears the ovary. Now with the second ligature, as there is no pressure in the vessels, can be either a surgeon's, as there is no bounce back, or a miller's. Always replace the top clamp, otherwise tissue tends to get caught in the ligature. I decided to demonstrate a surgeon's for the second ligature. Tie so the knot is on the opposite side, and try and keep it low. As the knot is on this side, you can check it's tight, as it digs into the pedicle. One of the largest advantages of this technique is we can check for bleeding in a safe position. Release both clamps and look for bleeds. If your ligatures were hopeless, blood would be spurting everywhere. Once you are happy there are no bleeds, replace the clamp and make sure you are clearing the ovary. If there is a bleeder, simply replace the clamp and add more ligatures. Using the blade to cut means you can get flush to the clamp. We have already checked for any bleeders, so doing this precarious way of checking is not necessary and is dangerous. When there is so much fat obscuring the uterus, you may have to release the clamp, reposition and reapply the clamp. Trying to find the uterine vessel is quite difficult in this one. Now clamp the broad ligament and reapply the uterine clamp. A surgeon's ligament should suffice for the broad ligament. With all this fat, finding the other side is probably going to be difficult. Pull a little on the uterus and start trying to feel the bifurcation inside. As I can't feel it, I check the other side in case the uterus is twisted, and immediately it becomes visible. With this dog signal meant, there is a chance ligatures could cut through the uterus. Crush beds are not worth the risk. A surgeon's knot is placed first, as this is least likely to cut through, and then followed with another Miller's and sometimes a transfixer. Slow uterine bleeds are a common post-op possibility. Remember, the smaller size the suture material, the more likely the suture will cut through. Cheese wire. There is a large amount of fat around the uterus, as the uterine vessels divert away steeply. Some vets may ligate these separate. With this dog, I decided to place to surgeons followed by a Miller's. I opted for this combination because the uterus was like a mass of fat, and finding the center of the uterus to place a transfixer was not possible. Whenever you can, avoid leaving crush beds in dogs. It has been shown to increase post-op pain and discomfort. I usually close the rescue dogs with cruciate ligatures instead of a continence pattern, as following the surgery, the dogs are usually bouncing around in their kennel, so if a knot fails, evisceration cannot occur. I place one cranially and caudally, as it is easier to place them now rather than at the end, especially if the muscle opening underruns the skin. For the fat layer, simple continence, starting deep superficial on the first side, then superficial deep on the other side, so the knot is hidden. The first pass has to be deep superficial, so the knot stays hidden. Finish with a surgeon's or Aberdeen with a 2-pass. A surgeon's is more stable. The knot has to be hidden before going into the intradermals. I usually do this by going through deep, cranial to the knot, coming out in the intradermal position. Try and leave a small hole at the end. This is so you can bury the knot easily by passing the needle through the hole. If you finish with an Aberdeen, it has been proven, the knot is less likely to fall apart. If you pass the needle through twice on finishing, snip the short tail as small as possible. It is essential this knot is buried. If it sits between the skin, edge-to-edge healing will not occur, and partial wound breakdown can occur 2 to 3 weeks post-op. Pass the needle close to the knot, deep into the wound and exit far away from the wound. Pull the skin over the needle to help with this. If not burying, then pull back out and go again. Try pulling on the suture a little, but also push the skin over the knot if all else fails. Change the needle to a larger one and this will make a passage for the knot to follow.